to ask, to respond to the question, how to optimize cardiac breast irradiation.
Thank you very much. So I think that my talk will simply reiterate a lot of the points that were just made in the previous talk about cardiac toxicity in the setting of trastuzumab, and I'll try to speak just a little bit more generally about cardiac toxicity in the setting of breast radiation in general. So by way of background, I think all of us in this room are familiar by now with the realization that radiation for breast cancer can impact cardiac mortality. The earliest findings related to cardiac mortality rather than cardiac morbidity, cardiac events, and this was a sort of a realization that came about after many decades of radiation in the pre-CT planning era, when, especially in left-sided disease, tangent radiation fields exposed the heart, and we were not able to calculate the radiation exposure or the dose and didn't really understand the impact of radiation on the heart. But the Oxford Overview's large meta-analysis of many randomized studies have clearly demonstrated that, particularly in earlier eras, that radiation to the heart, to the breast, while reducing local regional recurrence and improving survival overall, does or has the potential to increase mortality specifically from cardiac disease. And this is a curve just showing a 1.3% increase in non-breast cancer mortality in patients who received radiation for the breast, again, generally in a kind of early era radiation studies. This is another SEER analysis, which is a large U.S. database containing over 300,000 patients who were treated with radiation. And this compares outcomes for patients on the left side of the panel. This is patients who received no radiation. And on the right side of the panel, patients who received radiation. And this is comparing outcomes between patients with left-sided disease and right-sided disease. So as you can see from this data, it goes back to 1973. So again, not aware of what the specific cardiac exposure or cardiac dose was. As you would expect in the no radiation group, there's no difference in mortality between left-sided and right-sided disease. But in the radiotherapy patients, there was an increase in mortality, presumably directly related to cardiac exposure. This is the same data set, but breaking down patients by treatment era. And the top panel looks at patients diagnosed between 1973 and 1982, and the way bottom panel goes from 1993 to 2001. So the bottom panel, just because it's a bit more recent, has a bit shorter follow-up, so not as many years. But what a trend does begin to emerge, suggesting two things. First of all, if we look in the panel from 1973 to 1982, that the risk of cardiac mortality appears to be late. So the top bar looking at the first 5 years shows a very minimal increase in cardiac mortality for left-sided versus right-side. But when we get up to 15 years of follow-up, that difference is more pronounced. And then the other observation is that there is a difference by treatment era, with patients being treated more recently having a lower risk over time. Now, this study doesn't help us elucidate why that would be, but I think that we have to recognize that during this time period, the primary improvement has been in technology. So in the modern era, the question remains, is cardiotoxicity really a relevant endpoint? And this is a picture showing a patient being treated to the prone breast, breast radiation only. Most of the pictures that we look at of radiation fields show us the radiation beam edge, and we feel very confident looking at this and seeing that the heart is out of the radiation beam path. But we do know that there is cardiac exposure even behind the back edge of our tangent fields. And when we turn on the very lowest dose of radiation, there is going to be exposure even in a patient who has the heart completely blocked out of the radiation field. So this is an example of a prone breast patient, left-sided, and the mean heart dose is 1.6 gray in this particular example. On the flip side, if we have a patient being treated supine with treatment of the internal mammary lymph nodes, despite our best technology, there is very often a higher radiation exposure. And in this particular case, the mean heart dose is 3.2 gray. So there's going to be variability in our cardiac exposure depending on our technique and also depending on our target, what we're trying to radiate. There are two studies that directly correlate the radiation dose to the risk of cardiac events. So this is probably the first study that made a big splash that really directly correlated radiation dose with cardiac events. So the prior data that I showed you was cardiac mortality. And remember that that reflected that there was this very late risk of cardiac mortality from heart exposure from breast radiation. But the more recent data has been able to elucidate not just cardiac mortality, but cardiac events of any sort, even if they don't lead to death. And so this is a case-controlled study of patients who were treated for breast cancer. One of the critiques of this study is that it didn't have patient-specific dosimetry. So they took a sort of a standardized patient and put the tangent fields onto those patients to try to understand what the cardiac exposure may have been, but this was not calculated on what the actual cardiac exposure was for each patient. But nonetheless, this trend emerged, showing a relationship between the mean heart dose and the risk of major coronary events, and showing that that risk increased with cardiac dose. What is also interesting about this data, if we look at the time course, is that, remember that we said that death is something that happens, generally speaking, later, but the greatest risk of coronary events from this data set was in an earlier time frame, with an increased risk of 16.3% in the first 4 years and then up 15.5% in years 5 through 9. So again, this concept that when we look at events, that there is a little bit of an earlier time course of risk. Subsequently, a study was done out of the Netherlands that tried to sort of reproduce the results from the previous study that I just showed you, the Darby study. And so this is a very similar study, but what is unique about it and sort of better about it than the Darby study is that they actually do have CT planning for each of the patients. So the cardiac dose was calculated on a patient-specific level. But this is also a study that tries to validate the Darby study that we just looked at, and again correlates cardiac dose with acute coronary events. And what is interesting is that with the benefit of patient-specific dosimetry, we see very similar results to what was seen in the Darby study. And when we look in the first 9 years, the risk per gray with mean heart dose is virtually the same. So this is sort of confirmatory data that the mean heart dose does correlate with the risk of coronary events over time. What's interesting to see is that when we looked at the spectrum of cardiac exposure in the patients included in this study, it was pretty wide. You can see some patients with a mean heart dose going up to 15 gray, but the majority hovering between 3 and 5 gray. The average was a mean heart dose of 3 gray in this study, and that would obviously vary with patient anatomy and with the radiation target. But we talked about one of the big changes that has happened from kind of early treatment era to modern treatment era is the improvements in technology, and with that, our ability to reduce radiation dose to the heart. I think that also comes with the awareness that there is a direct correlation. And so this is a study from the University of Michigan that looked at what the average heart exposure was in kind of an early treatment era versus a contemporary treatment era. And then in patients who had internal mammary nodes treated or not treated. And so specifically, the circle is looking at patients with internal mammary node treatment and looking at the contemporary patients with an average mean heart dose of 1.8 gray versus earlier era 4.8 gray. And this was correlated with a non-significant increase in the 10-year risk of ischemic heart disease. So sort of the summary, I think, from this is that good planning and attention to detail pays off. So just by focusing on cardiac exposure, the mean cardiac dose on average was able to be decreased in this particular health system. Going back to the data from the Netherlands that we just looked at correlating the mean heart dose, this study, because it had specific patient dosimetry, was also able to look at other cardiac parameters aside from just the mean heart dose. And the panels that we're looking at here show the left ventricle V5, or the volume of the left ventricle specifically that receives 5 gray. And what we can see is that there are significant differences in the risk by multiple factors. First of all, the dose to the left ventricle. Second of all, the patient age. The different colored bars that we see on these graphs show different patient ages. And what we can see across the board in all of the panels is that the risk of coronary events is greater for older patients who are treated with radiation than for younger patients who are treated with radiation. And then the third thing is risk factors: diabetes, hypertension, and prior cardiac events. So in the bottom right panel, we can see patients with prior cardiac events are those who are at the greatest risk of developing future cardiac events related both to the dose and to the patient age. And I think this is particularly important for us. I know myself, before understanding this current data, I was more worried about cardiac risk in younger patients because of the understanding that these patients had a longer life expectancy, a longer lifetime of risk for cardiac sequelae. And it's not that we shouldn't take that very seriously, but the data, I think, at this point is consistently showing that older patients, despite perhaps having a shorter life expectancy, are actually at a greater risk of developing cardiac sequelae from radiation than younger patients. So that's just something that has been a shift in my thinking over time. So just to sort of summarize the significance of the data that we're just looking at, if we have a patient who is 70 years of age, who has an LVV5 of 50% and no cardiac risk factors, her excess risk over her lifetime of developing a coronary event is only 2.5%. And if we have the same exact patient who has a prior history of ischemic heart disease, it's an excess risk of 8.4%. So there's going to be a lot of variability, particularly with respect to risk factors and with age. I'm going to skip through that. So generally speaking, I think we have learned that breast cancer treatment can impact cardiac mortality, and more recently we're understanding cardiac events, which can happen earlier than mortality, and that there does appear to be a pretty clear dose-response relationship. The exact dose threshold doesn't seem to be identified, so even patients who have very low cardiac exposure probably have some increased risk, even though that increase is going to be very small. So I'm just going to jump ahead to some of the dose constraints that are utilized in our current, the study that I mentioned in the previous talk, the RTOG B51 looking at regional lymph node radiation, yes or no for patients who convert from lymph node positive to lymph node negative with preoperative systemic therapy, utilizes these dose constraints. So the dose to the heart, 20 gray to less than 5% of the contoured heart, 10 gray to less than 30% of the contoured heart, and a mean dose of less than 4 gray. Those are the constraints that are proposed by the study. I would say that in the US, we strive for even lower doses than that, particularly the mean heart dose. We recognize that we often have the ability to get even lower than 4 gray, in particular in patients who don't need lymph node radiation. So in my personal practice, I strive for a mean heart dose less than 2 gray. Not that we will always achieve that, but that is the goal. And then based on the data that I just showed you from the Netherlands, we've begun to contour the left ventricle and to aim to keep the left ventricle V5 as low as possible as well. Just a brief word on contouring the heart, because so much of the dose calculation to the heart is going to depend on how we contour it. So the guidelines tell us to have the superior most cardiac contour at the level of the bifurcation of the pulmonary trunk into the pulmonary arteries. So you'll find with that you do have some of the major vessels in your cardiac contour. And then the other thing that is important is to differentiate between the pericardial fat, the pericardium, and the myocardium, or the heart muscle itself. And the vessels, the left anterior descending artery, for example, are generally contained within the pericardium, but outside of the myocardium of the heart. And those vessels presumably are a significant portion of what's at risk in addition to the myocardium. So this is just a particularly nice image in that you can see very faintly the pericardium in this image. And you can also see some of the vessels in the pericardial fat within the pericardium. So when we're contouring the heart, we want to make sure that we're going superior enough all the way up to the bifurcation of the pulmonary arteries, and that we attempt with the best of our ability, it's not always so apparent on a CT scan, but attempt to contour the myocardium, the muscle, but also include the pericardium, because that's where the vessels of interest are going to be located. The last thing I want to mention is this US study that we have comparing protons and photons. I'm presenting this study primarily because what is most interesting about it is that it's looking at a radiation technique question to see if the decrease in heart dose with the utilization of protons results in fewer cardiac events. So I'm not using this study to promote protons, but simply to point out that this is a very interesting question that's being asked about the correlation between dose and coronary events. So again, this is a randomized study for patients who will require internal mammary lymph node radiation, and they're being randomized to proton radiation, where the estimated mean heart dose should be less than 1 gray, even for patients who need internal mammary lymph node radiation, versus photon radiation. For the purposes of the study, you can see that they've estimated that the mean heart dose would be on average between 4 and 9 gray. I think many of us try to do better than that, but the statistics for this study are based on the idea that we'll have a meaningful dose reduction with proton radiation versus photon radiation, and again, it's randomized. And the endpoint of the study is major coronary events, with the hypothesis that by reducing cardiac exposure, we will reduce major coronary events in patients with breast cancer. So this is the first large randomized study that I'm aware of to look at a cardiac endpoint for breast cancer as the primary purpose of the study. So whether or not this leads to protons being more widely utilized, I don't know. But I think that if the results do show lower coronary events, it will at least make the argument strongly that reducing dose can have an impact on patients' subsequent risk. So I would just summarize by saying that, yes, I do think that cardiotoxicity remains a relevant concern for many of our patients who are treated with radiation. It's very, very difficult to study because of the long natural history of developing heart disease, the fact that there's such a wide range of cardiac exposure in our patients. But I'd say the primary cardioprotective strategy that we can use is just thinking about techniques and technology to reduce cardiac exposure and to tailor our decisions. We've talked a little bit earlier in the session about decision making about who needs regional lymph node radiation, who needs post-mastectomy radiation, and to think very carefully about weighing cardiac risk in that decision about when and who to treat. Thank you very much.
Thank you. Thank you.